Afternoon. My name's David Knox, and I have MSA, multiple system atrophy. I figured it would be easier just to go live and explain things across multiple platforms today. Forgive my speech issues, but that's the way it is with MSA. So I'm going to show you a couple of things and illustrate what goes on with swallowing with dysphagia. Dysphagia is trouble with swallowing, and there are many things that can go wrong with dysphagia. Many different parts of your entire esophagus, your throat, your windpipes. I mean, mouth, teeth, gums, tongue, everything. Even something called the epiglottis, which we'll get to. So I was having some severe saliva pulling, which I've had before. And before we get going too far, I just want to say that for Daisy and I are working up a podcast hopefully the upcoming week. We had a couple of technical difficulties, and we tried for this week, but we couldn't make it work out. So next week for that, hopefully. But this affects both of Daisy and I together, maybe in different ways. But swallowing is something big. You've always seen Daisy swallowing uh, food during our podcast. Well, she's taking it with medication, right? She's taking thickening food, just like I have certain things I use as thick versus thin, and some things are thinner than thick. So I was complaining about some saliva pulling and swallowing issues getting worse. Just not saliva in the back of the throat, but very thick saliva that you can't even spit out. Um, Very weird for somebody who's never had that type of thing. And I can only compare it to like having the flu or upper respiratory infection, pneumonia, and you're coughing phlegm, but the phlegm doesn't want to come out. So that was my initial, what do you want to say, complaint. And the doctors wanted me to go ahead and have another modified barium swallow test. So I was like, oh, great, another one, Well, the last one showed um, penetration of fine liquids, which I'm going to show you what that actually looks like. So I don't have the video from this past modified barium test, but I do have the one from before, and with a little bit of pointing with a cursor, I can help you see exactly what the differences are. So I will share a screen with you, and I'm going to share. So we're going to read. Let me see here. Yeah, we're going to read what the report actually said. There we go. So in yellow, basically, right? It says patient presented with mild oral pharyngeal dysphagia. Never gonna say it again. Characterized by adequate safety of the swallow, but reduced efficiency of the swallow. The patient had reduced propulsion of the bolus to the posterior portion of the oral cavity, which contributed to residue consistently in the posterior portion of the oral cavity after the initial swallow. The patient also had consistent residue on the tongue base, keyword there, base, tongue base, after the initial swallow. The patient was able to reduce this material with a dry swallow if the viscosity of the material was low, thin liquid, right? Kind of like oil in cars. However, as the viscosity increased, he required a liquid wash and the dry swallow to reduce, to break it down. The patient's epiglottis does appear to be flaccid not moving, just laying there against the tongue base, which does place him at a higher risk of aspiration if he does not trigger a timely swallow. So now I have to worry about swallowing in a timely manner with things. So, and I say it just gets a little bit more interesting um, the more that goes on here. Where were we? Um, However, he does appear to achieve closure of the laryngeal vestibule during a swallow. I'll point that out because it's very important. The patient is also at risk of postprandial aspiration, or with residue of the tongue, which is residue on the tongue at the base and pharynx, since the closed or flaccid position of the epiglottis does cause material to travel to the posterior side of the epiglottis versus pooling in the valleculi. I'll show you these points on a presentation here. So, ongoing treatment that we're going to have is speech therapy for swallowing. Which I didn't realize swallowing followed under speech therapy, but it makes sense after a while. So let me show you what we're up against here. I actually have the video from the old. This is from March 5th of this year, 2025, and we have a couple of issues. Well, let me explain a few things. A, I had to scroll with my mouse button for this to work properly. And B, there's a lot of slides. So I'll try my best to make this as normal looking as possible. So obviously we see all the teeth now. Ignore the screws and plates and metals and stuff. Yeah, that's from a surgery I had before, but a birth defect. So the mouth is here, and the tongue, which you can see is much denser, dark, actually extends all the way down until where the airway starts, which is right where my mouse is right here. This area right here is the part of the body that goes straight to your stomach. Okay, straight to your stomach, straight down, boom. So the tongue not only is it huge, but it wraps around basically to the base of where you inhale at. And when we go to swallow, so here goes some liquid. You can tell by how level it is. So pay attention to this part right here, where the upper part of the this is where penetration would be going before it gets to the trachea to the lungs. This is to the stomach, but it's going to move in an upwards motion, and it will be closed. There you go. So the muscle right here at the base of the tongue is responsible for closing the airway so that food and liquid does not enter the airway. So if even after this, you can see the area is now expanded, the upper airway, upper tract, and you can see the residue from this is back from March, but you can also see penetration. So when they talk about penetration of your airways, this is penetration. It is only aspiration if it gets through the upper tract and actually gets into the airways. So we mainly feel like we're choking, we're aspirating, is food or liquid penetrating into this area. That's called penetrating the upper tract. That's what we cough on. Very rarely does it actually get down into the actual airways for the lungs below this. You can see the difference in shading here. But it does happen. I mean, we're able to cough these things out to whatever, blow them out our own ways. The food, or liquid, or water that gets into the upper tract effectively, and only does it, if it passes past this into the actual lungs, do we get aspiration pneumonia. So something to keep in mind, that most of the choking you're seeing, that you're feeling that you're aspirating, is in the upper tract, upper airway. Okay, upper airway. And there are absolutely many views of the liquids and solids doing the same exact thing. Now, you can see this again, the tongue. This is liquids as well, wrapping all the way around to the base. And it's the let me see what it was. Um, the epiglottis is that flap. That's the flap right here. That's going to close and seal off the airway from the actual going to the stomach. And as you swallow, it does seal it off so that you don't see very much going. Again, at this time I was penetrating much fine liquids. You can see all the liquids that are the black that are still in here. It happens. So swallowing is just not a fine art. I found something out when I was talking and doing these tests. I was just a cracker chewing it up with liquid. And again, epiglottis, the flap, is going to block off right here the airway so that the food and liquid can pass through to the stomach. And there you go. It does. But as you can see, I still have residual. Basically, you're looking for black. And this one is not a lot, but you can see it residual on the tongue and the back, throat lining, and it has, in fact, it's penetrating the fine liquids. Now, the good news about this past test I had is that the penetration has not happening anymore. So either the Botox or the in combination with the stem cells has helped out a lot. I mean, you can see before and after. My issue was thin liquids at this time. So chewing crackers and stuff really isn't going to make anything happen. Um, have I choked on these things before? Absolutely. But have I aspirated food? No, it was only fine liquids. So I do a lot of chewing to just break down my food a lot. Awful lot. Especially when you give you crackers with this crazy paste on there. It's this food is too good. There you go. So crackers with a whole bunch of paste is not very hard to push through. Now, your throat here is just like anything else in your body. It's just like I hate to compare it like this, but it's just like your colon and your bladder. If these muscles don't work in sync, then you do not have a very fun time of passing anything properly, right? We all know what happens when you don't empty your bladder. You wet yourself on accident down the road, and B, you have UTIs. We know what happens if you don't empty your colon. Incontinence, and it's messy. Same thing with swallowing. If you cannot push your food and liquid down properly, then it's going to always be an issue. So the good news is I no longer have aspiration of the fine liquids that we had before, which is very nice. You can see right here, they actually highlighted the residual, right? After swallowing, here goes the residual fine liquids that they had. And this is the airway, the upper tract. This is your actual uh, pipes to your lungs, and this is sitting there, which means they also said my epiglottis is not. It's like it's limp. It's just sitting there. Well, if the epiglottis is not working properly, and I start to breathe right after I swallow, I have a very high chance of this matter, whether it's food or liquids, coming into my esophagus and into my lungs, especially the upper tract. And it made sense to me because I finally realized a couple of things. Let me shut this off for a second. I've realized two things this past visit. I tell my camera to take a picture. Unbelievable. Two things I've realized. One is the reason anesthesia is bad for us with MSA is because during anesthesia, our muscles don't move except for heart, lungs, brain, things like that. Right? We're put to sleep. We are comatose from the neck down, whatever. And I had aspiration pneumonia after my major left shoulder replacement surgery. It took quite a few hours for that. Doctors don't like us going under anesthesia because if the surgeons and anesthesiologists are not careful in watching the buildup of saliva or other material down there by our epiglottis, it will go into our lungs without them knowing and create aspiration pneumonia after the fact. I now have no doubt in my mind that because of that surgery, I'm not suing anybody, but because of this, my shoulder surgery, the next day or two, 3 or 4 days later, I had aspiration pneumonia because during surgery under anesthesia, some saliva or liquids got into my lungs because epiglottis was not working properly, and they simply just did not know to look for that. Right, the next surgery I'm going to have, I bet you that I'm going to make them aware of this issue so they can at least have it in the back of their minds, no matter if it's a short surgery or a long surgery. Okay, I've learned that anesthesia. It's not the anesthesia that's bad for us. I mean, sure, slowing down our breathing and our heart rate and whatever. Nothing is good for people with MSA, right? Chocolate is not good for people with MSA. Too much playing World of Tanks and Call of Duty and Battlefield is not good for people with MSA. Nothing is. But the anesthesia is primarily bad for us because it stops our muscles from moving during surgery, which is a good thing. But if you don't take care to watch out for saliva going down to your lungs or anything else for that matter, leftover food from eating the night before or drink or whatever, you come out with aspiration pneumonia. I bet you if you were to draw a correlation between patients with aspiration pneumonia and surgeries, you would see a direct correlation of a large percentage of having aspiration pneumonia after a surgery versus people that have aspiration pneumonia on their own with normal people, for instance. So I learned that by having a shoulder surgery the hard way and having respiratory pneumonia a couple of days later. Yeah, the second thing I realized was that I just forgot my second thing. um, you're told to not talk with your mouth full. As children, we're taught not to eat or not to talk with our mouth full, right? Still a big shout out to Gold Peak Tea. You're the best. But as children, we're taught that because it's improper. It's not proper etiquette. With MSA, it's life and death that you do not talk with your mouth full or while chewing or trying to eat anything. It's not life and death. Why? Because as you see on this very short animation, that black part in the middle of this black part, we actually go to a better one. I go. Where's my second? There it is. So as we swallow, we're constantly eating, we're constantly chewing and breathing and talking. But we should, when we go to swallow, do you breathe? You take a breath and then you swallow. Do any of us breathe and swallow at the same time? Impossible. Because the flap that closes for breathing and opens for eating is open or closed. Impossible to swallow and breathe at the same time, unless you're a genius somehow, right? For MSA patients, we still have leftover material, food, water, liquids, tacos, whatever, in our passageway down to our stomach. And if we have not fully taken our drinks or whatever and swallowed them properly, all the way down the stomach, then the moment we go to inhale, that flap opens for the lungs, and here comes the tacos into our upper tract, penetrating this area, the upper tract of the airway. That's how we know when we start coughing over food. And I noticed this with my doctor. I said, this makes perfect sense because most of the time that I'm aspirating on food is when I'm out eating with family or friends because we're talking and we're chewing. It takes us a lot longer than say to chew, right? And I will try to say something, but as you try to say something, you have to take a breath to speak. So we're chewing, and the moment you do that, you breathe in to say something as you're chewing, right? Even after you swallow some food, you are now diverting anything that's in between, anything that's down by here. Anything. Look at all this black material that still has not made its way down. And even though we did a quick swallow, but the cruise ship, for example, we still have foreign that matter that still has not made its way all the way down. So now it comes up for breathing and goes into our upper tract, like you can see the very left-hand part here. And now we are aspirating our food, even residual, right? This material has penetrated into the upper tract for breathing, not to the lungs yet, but the upper tract that makes you cough right here. And I still have a bunch more that's left over. So it is paramount that we do not speak while we're chewing food at any time. I was told specifically by these doctors, you eat, you focus on eating that bite at one time, and you wash. Not everything needs to wash because do you have to wash your wash? No. But, anything we're eating and stuff, you have to make sure it is all the way down and your throat is clear. So we have to go back to being kids now with NSA and do not talk with your mouth full at all, no matter how big chunks or little chunks or whatever. Even talking with the liquid in your mouth, you can still aspirate it as easy as potatoes. Notice my speaking issues, right? I have more MSA Parkinsonisms, more to find more control and tremors that is affecting me. I do have slurring, but people that are such as Daisy who slur everything MSAC. This is an impromptu video that I did not plan on making, so my voice is more broken up with tremors and find more control because I this is not typical for me. This is what you would hear on most on a good day. But even in speaking to my wife and mom and stuff, it gets much worse than this, especially if it's over the telephone. That's just the way it is. So here's what that did I move it? I did. Here's what that test showed me. And I will put it back up here for you. I will put that in layman's terms. I don't know why I say layman's terms. I don't know what a layman is. So somebody help me out one day with that. Make this easier for you and I. Here in yellow, okay? Now notice that there's R13.12 dysphagia. There are many types of dysphagia, many types, and this one is talking more about food and anything else. So very short thing here. This medical report can be complicated, but the language is called mild oral pharyngeal dysphagia. Now, my lower esophagus ring, right? Uh, what's it called? It's just like that. The terminology here. The oropharyngeal ring, my lower muscles is very weak, so I do get massive regurgitations back up into my throat because the ring of muscles that is supposed to keep that down in your stomach is beyond weak now. So I have to be careful not to eat too soon to sleeping because I can't control a lot of that matter. It's like vomiting in your throat, which is very different than vomiting in your mouth. It's a bad thing. So um, this report is good for me because during this entire test, I did not penetrate any fine liquids or anything for that matter into the upper tract of my airway. Great news for me. However, um, it's not very efficient. The tongue and throat muscles aren't pushing the food or liquid all the way back as strong as they should. So if I go back and show you this picture again of the swallowing, now the laryngeal ring is down here, which makes your stomach, and the muscles are not very weak and not very working very much anymore. So we still have that. This one though, if you notice the swallow, watch. This is the matter. This is the muscles. Everything in the light gray are muscles. There's some bone here, but let's get past that. Watch it work together and move it down. Swallow, squeeze at the top, and they're going to push. The white area right here is the opening to go down to the stomach. The muscles are working together to push down all the contents completely. And you will see them closed completely to to expel, to not to expel, but to ingest the food or liquid all the way down precisely. Kind of like what happens when an air balloon deflates, a balloon deflates of air. It goes all the way down and pushes all the air all the way out. My issue I have now, which I don't have a video for, is the muscles. There are specific muscles right here for swallowing that have now become just as weak as the bottom ones. So it's breaking my swallows up into multiple swallows. I'll swallow 80% down and 20%. I'm having too much material left over into my throat area and mouth that's not being swallowed because the tongue, which is a long tongue, it goes way down here. The muscles of the when she showed me the video, it was somewhere right here that part did not make contact, therefore was trapping parts of the food and liquid in the middle of the throat, which makes it even more likely to aspirate because it's not at the top of it's not by your mouth, it's not in your stomach, it's dead in the middle, which is where you do not want material to be at all. So that's really where this came from on this last visit I had on the 10th of October of this year, 2025. So um, not swallowing, tongue and throat muscles aren't pushing the food or liquid all the way back as strongly as it should. I wrote this down so it's a little bit easier to read. Because of that, a little bit of food or liquid tends to stay behind the mouth or the back of the tongue after swallowing, so that we feel. If they're drinking something thin like water, they can usually clear it out by just swallowing again. But if the food is thicker like mashed potatoes or pudding, they might need to take a sip of liquid and swallow again to help wash it down. That's what I've been instructed to do, always, from now on. Now, another piece of what we talked about was the epiglottis. It's that tiny little flap that protects our airway when we swallow. I showed you examples of that flap that closes in between our which is, the flap is right here when we swallow or when we breathe. Hard to see on this, but it's there. There's a flap right here that's closing to allow food to come down straight down to the stomach instead of diverting forward in the body into the upper tract of the airway and then down for aspiration. So, too quick for me to point that out where that flap is, but it is there. I believe it is actually right here. You can see the material. Okay. Oops. Lost myself. Not good when you lose yourself. So in my case, it's a bit floppy, not working very well, which raises the risk that something could go down the wrong pipe if the person doesn't swallow fast enough. So not only do I have to make sure I swallow forcibly and correctly in one swallow, wash or whatever, but it has to go quick. Yeah, we have to propel our contents to our stomach as fast as possible, which is why physical therapy for swallowing is needed. I'm not used to. I mean, that's automatic, right? Autonomic system fails. So the central nervous system, we take this stuff for granted, right? The good thing is once they do swallow, the airway closes properly, so they're still protected during our swallow. What doctors worry about most is what happens after us eating. Because a little residue, which you've seen on the video, is left behind under the tongue or in the throat, some of it can slip into the airway later, what we call post-meal aspiration. That's why training and awareness are important. How many I can tell you 1,000 times, but my wife will attest to this. The damn Mexican tortilla chips, I love them to death, but she has a bag upstairs of the most the best tortilla chips. So she has this bag of it's tormenting me for the last 2 or 3 years. She doesn't know. She does not know this, but I had them before, and I paid a heavy price because they're so thin and crispy and like buttery. They're just delicate for being a chip. And I pay severely when I eat those because even after the fact, whether it's here, home, or even when I had this test in March, by the time I took the elevator up to the doctor's office to talk about it, I had that the crackers that I had swallowed during the test had aspirated into my that had penetrated into the upper tract of my lung, making me like choking, like crying at the elevator. People were wondering if I'm okay, if I'm dying or need the Heimlich maneuver, right? After that, even after the test at the hospital, I got foreign matter into the wrong part of my airway in between that and the doctor's visit, which was like 2 minutes away, right, one floor up. So, but those tortilla chips, oh, they're so good. Um, so post meal aspiration is a very important thing. That's why they say to, and I'm always drinking. It's important to wash down once, twice, three, however many times it takes to wash down your food, because if you have, we all have teeth, obviously. And we know that eating certain foods will, especially crunchy foods, will, you got to use your tongue. You're trying to get the pieces out so you can swallow them. Well, with us, if anything like that's ever left there, even if we can't feel it, we're going to aspirate that very quickly. So that's called post meal aspiration. So the goal of this is very simple: it's to keep enjoying a regular diet on thin liquids safely. So the therapy that we're thinking about here are compensatory strategies, things like posture adjustments, swallowing techniques, and taking time between bites to make swallowing safer and more efficient. I know that when I choke on a pill, because of the way some of my muscles aren't working anymore and my vocal cords, one of them is paralyzed. If I choke on a pill, I look to the left and swallow, and it goes down. Very surprising because there's something wrong with some the part of my throat that for one side of my throat is not working properly. Therefore, all I know is turn left and swallow, and it works for me. Right. So, um, trying to keep very normal behaviors, but this is making things more safe and efficient is a great example of how small adjustments and understanding your body can make a big difference in quality of life. And knowledge really is power for anyone dealing with swallowing issues. Remember, there's therapy and other ways to adapt. And the adapting for me is honestly to shut up and swallow. I know it's not politically correct, but you know, it, I'm 45, and it just hit me why we don't talk with our mouths full. It's not only because of etiquette, but for people that have issues with any type of issues of swallowing, MSA or not, Parkinson's, whatever, we will aspirate. Even if you're a normal human being, how many times have you choked in your entire life on food on an accident? Because it's probably because you were taking a breath, trying to breathe or speak, same thing, while you have some type of material, foreign matter still in your throat. It makes perfect sense now. And also the aspiration pneumonia makes sense because these muscles are not moving during anesthesia. Therefore, we aspirate saliva. And here we go with our own aspiration pneumonia created by ourselves because we had the surgery trying to help ourselves out, right? So I just want to say that Daisy and I appreciate you very much. I hope the logos are all facing the right way. This is off the cuff, but um, Daisy has a very cool technique she's going to try for our next podcast for speaking. And I'm not going to ruin it, but sometimes we do have technical hurdles and things like that. So we will be back with another podcast. But until then, she has released a new her and Kerry Carpenter have released another um, album called "Take It Day by Day." And if you look for it, it says "Take It Day by Day." And it has a forest with a wheelchair with the road on fire, so to speak. So, um, very good songs. I enjoy them very much, and I hope you enjoyed this live stream for right now. Being very honest, I'm being me. This is the normal me. This is who I am, and you know, I don't want to make this about stem cells or anything else, but things are going okay for me. I'm just battling a shoulder. Daisy and I definitely appreciate you. And those of you that joining me on my MSD Strong YouTube channel, we appreciate you. So if you found this helpful, give me some feedback. Give us some feedback. Mainly me, I guess. And we'll see how it goes. But other than that, we appreciate you. We'll definitely see you in the next video, and there will be more videos. We promise. Have a good one. Thank you.